So, good morning.
Yes.
All right, may I? Good
Yes,
morning, everyone, and welcome. The G60, a concept that we have brought about is to get some really wonderful people who've been involved in researching into an area of their interest, and that they get a lot of time to speak on whatever it is that they've been working on for so many years, so that you get to hear from them their perspective of their work, actually. And I'd like to welcome Professor Bill Morgan and Dr. Surinder Pandav. Dr. Surinder Pandav is also chairman of this program. And Dr. Surinder Pandav is very well known to all of us in India. He's a glaucoma specialist, and he's professor of ophthalmology at Postgraduate Institute Advanced Eye Care Center in Chandigarh. And he's been involved in a significant amount of research. Welcome, Dr. Surinder, and I'd ask Dr. Surinder to take over now and introduce our distinguished lecturer, Professor Bill Morgan.
Thank you, Vinay, and thank you for organizing this program and looking after all the logistics. It's my pleasure indeed to welcome Professor William Huxley Morgan, Bill Morgan. I have known him for many, many years, and I have very fond memories of Perth when I was there. Professor Morgan is Managing Director at Lions Eye Institute currently. He is also a board member of the Lions Eye Institute. He is visiting professor to the Udayana University, Indonesia. He is head of the department at Royal Perth Hospital as well as Princess Margaret Hospitals. Both of these hospitals are located in Perth. His research interests include glaucoma surgery, but he's also very passionate about community service, especially I have seen he has a lot of respect and regard for the indigenous community of Australia. And I remember visiting Kalgoorlie actually along with him many years ago. Kalgoorlie is a desert area, and there's a lot of indigenous population there, as well as a lot of gold mines actually. We had a fun time at that time. Professor Morgan did his PhD in optic neurophysiology from University of Western Australia, and there he was involved in groundbreaking research on pressure gradient across optic disc, and subsequently he carried on this work on retinal venous pulsations and its relationship with CSF pressure and glaucoma. So both of these works have been very widely appreciated and cited. He has published over 150 papers with over 3,400 citations and with an H-index of 32. So he is a very well-established researcher who is known all over. He holds 7 patents, but as today's meeting indicates, he is the inventor of the Xen implant, which has actually become very popular and helping a lot of patients who suffer from glaucoma. He is also co-inventor of Verna GDT. This has been introduced in Indonesia. I think it's available there now. So Bill, it has been a very pleasure to be associated with you, and it's really my proud pleasure and privilege actually to introduce you to our audiences here. And I'm sure with your experience in Xen implant and how you brought about this research and how it became an actual product, I'm sure the journey is very fascinating, and our audiences and we'll all like to know from you how you did it. Thank you very much once again for coming on, giving your time to us. And now I pass it on to Dr. Bill Morgan for his talk. Thank you.
Thank you very much, Surinder. Thank you everyone for coming. I can't see your faces, but I remember coming to India in February and also several times prior, and I really enjoy coming. The only thing I don't enjoy is when we lose the cricket, but anyway, I have to accept that. I always enjoy listening to the Australia versus Indian cricket matches. Now, I wanted to just try and tell you the story of the Xen, or rather gelatin microfistulae, And I want to thank my co-workers here, and there were many people. Professor Dao Yu was the prime motivator and is the real inventor of the Xen. He thought of the idea and also thought of the technique for implanting the tube. Now, what you're seeing on your screen, the video, is our actual first human patient that we did this on back in 2007. But now let's take you through some of the story. So an ideal glaucoma operation, this is what we would all love. So ideally we wanted to minimize trauma, particularly trauma to the conjunctiva. Probably if it can generate a bleb that functions well, that would be ideal. Our most successful glaucoma pressure lowering operations all seem to involve the creation of a bleb. If we could maintain the primary aqueous, so the least toxic aqueous, so that we don't get too much scarring and damage in the conjunctiva, and to maximize lymphatic connections. And I mentioned before minimizing fibrosis. And there's a lot that we don't understand about glaucoma surgery, particularly bleb formation and bleb maintenance. And I'll show you some interesting work on the lymphatic connections in a little while. So the original idea for this operation was to create a cross-linked gelatin stent, basically. We thought it would take a long time to dissolve, and that was in the original patent we wrote in 1996. The advantage of gelatin is that it's very biocompatible. So it's rather like a tendon type tissue. It's made out of collagen basically. And another advantage is that it would become soft and become quite flexible. So it acts a little bit like a blood vessel. So one of the problems, as you know, with the glaucoma drainage device using a silicone tube is that they're quite rigid really, and they also have what we call memory, as in the tube to want to become straight. They don't really want to stay curved and follow the contour of the eye. So we wanted a material that would have memory and would become flexible and also reduce trauma, particularly conjunctival trauma. The original thought we had back in the mid-1990s was that we imagined the endothelial cells growing along the actual stent itself. That proved to be false, actually, but never mind, the actual rest of the idea seemed to work. Now, this is the current sort of commercial version. This is the Xen, Allergan Xen stent pictures on the right, and that came out of the patent, which you'll see below, back in 1996. In essence, we wanted to make a very biocompatible material and stent. The other side of it was we had to deliver the stent with minimal trauma. So that meant an ab interno procedure. So coming across the eye, but controlling the eye position and visualization. And I'll get onto that in a minute. So it wasn't just making the stent, it was actually delivering the stent in a very controlled fashion. So this is the first page from the original patent with the original diagrams back in 1996. And the original work, I did some of the original work, but the technique I worked on actually failed. Professor Yu's wife, Ning, who is a cardiologist, came up with the best way of making the Zens, or the gelatin stents, and that was a dipping accretion method. Basically, the gelatin was formed in a highly concentrated solution, and then we would use a wire to dip in and out and dry. And then when we had the gelatin around the wire, we would take it off and then cross-link it with glutaraldehyde in a special oven. And Professor Yu spent several years working out the parameters to best cross-link the gelatin using biochemical techniques. Then he and others worked on a robotic system to introduce the stent into the eye of animals. Originally we used animals, and then we moved on to working with Chinese colleagues in Shanghai on monkeys. So this is from a rabbit. This is some months after the Xen implant, the histology of the Xen. So it looks like, we're not sure if these are epithelial cells. They're probably fibroblasts lining the tube, but you can see that there's very little inflammation or reaction in the tissue lining the tube. Most times, if you do this with a silicone tube, for example, a Multino or a Barvelt or any other silicone tube, you will see a lot of morphonucleocytes and lymphocytes, as well as giant cells often lining the area around the tube and the plate. But here you don't see any of that. It's almost as if someone has neatly carved a tunnel through the sclera. So this is just a collage of images from the initial rabbit eyes, and you can see we used a modified Schwann-Jacob gonio lens. This needle assembly, which contained the Zens, the gelatin stent, was connected actually to a robotic introducer system, and I think I have a photograph to show you. And essentially we used an ab interno approach, gonioscopic control, and then delivery of the stent through the sclera, and here you can see a bleb forming in the rabbit eye. And those blebs in the rabbits typically lasted a few months, which was longer than a trabeculectomy in a rabbit, which will generally only last about 1 month from other work that we've done. Now, what we also did do in rabbits and monkeys was looked at what was happening to the aqueous humor as the aqueous went through the gelatin stent and into the bleb. And here, for example, you can see fluorescein dye filling the anterior chamber, and then we switch to the fluorescein filter, and you can see the dye in the anterior chamber. And then there's a bleb forming, and the bleb forming here, and you can see tiny little lymphatic vessels being lit up. And here, this is a much nicer photograph. And what we've also done in this animal is injected some trypan blue or vision blue under the conjunctiva, which has been taken up by lymphatics. And you can see the blue, trypan blue dye, as well as the fluorescein dye, filling the same vessels. So in this manner, we were able to prove that the drainage from the blebs was going out through the lymphatics in both monkeys and rabbits. The other point to note was that 80% of blebs with lymphatics, this is in the monkeys, lasted about 3 years, whereas 20% of the blebs that had no lymphatic connections in the monkeys, they only lasted about 2 to 3 months. So seeing the lymphatic connections was an important sign of success in the animals. So this is a photograph of the initial introducer, and this is the robotic assembly system that was made in our laboratory with joystick controls, operating microscope for the animal work. Clearly that's not practical in an operating theatre. The other thing that oh, sorry, I'm not used to this system. Sorry about this. I'm just going to shift some of the webinar stuff. Yeah, there we go. So what you'll notice is that the robotic control system used a guide wire, and this is the inner light green here, to stabilize the position of the stent, which is in yellow. And then the blue is a plunger, which was able to push the stent. And the outer lining was a 25 gauge needle, which is still basically used. I think it might be a 27 gauge needle now, but we used initially a 25 gauge needle. And the original stents that we made had a diameter of 220 microns, whereas the current Xen stent is only 90 microns. But essentially, we would position the needle through the sclera, and then the robotic or computer control system would push the stent a little further into the subconjunctival space, and then retract the needle into the anterior chamber, and basically release the stent into the sclera. And further, as it turned out, we didn't actually need this guide wire, so that got removed, and that made the introducing machinery much simpler and easier to manufacture. Oh, sorry. Now, so as it turned out, this was the first commercial version for human trials, and this was back in 2007, and we had to, in the operating theatre, we still had a motor control system, but we used this tiny disposable plunger system with a 25 gauge needle hooked up to some little motors. I think I've got yeah, here we go. So this is it here, and it connected up to this box, which the nurses ran. We had a foot pedal switch so we could control the motors, and then we could deliver the Xen stent into patients, and I think you saw the first video. So this was a bit cumbersome. It meant you had to do some assembly in the operating theatre. It became simplified to this tiny little device which had some motors in it, which was also not very easy to hold, so that became further refined by Aquasys, who were the venture capital people at the time. Now here you can see the 25 gauge needle. This is the guide wire that we did use, but which we stopped using. This is the actual stent being pushed out of the 25 gauge needle. So we began a human trial in 2007, and Professor Yu and I inserted 4 over several months and watched them very cautiously. I was very nervous about it on real patients, and so it wasn't until probably 2009, when we were happy that those 4 patients were doing very well, that we started doing more and more of these. Now, during that time, the venture capital firm set up their American advisory committee, and they advised them to stop using bovine or cow gelatin. They were worried about mad cow disease or prion disease, and so the cross-linked gelatin was switched to using pig or porcine gelatin. So that was one change. It hasn't affected the physical properties, it was simply a manufacturing change. And during that time, the actual delivery system became further simplified as well. We also worked on an eye fixation system and a special gonio lens system that I'll show you. This is an example of pretty much what we still do, and that was what we were doing back in 2000. It's a special gonio lens made out of 1.9 refractive index glass. So it sits on the cornea with viscoelastic, and it allows you to enter the eye ab interno, look at the angle of the eye, but also look at the exit point here in the conjunctiva as you pass the needle assembly. Now, the original surgery did not require viscoelastic, but the company changed the design and introduced what we call a shoulder on the needle, so that we had to then begin using viscoelastic. So you'll see this is still present, this shoulder here, which means that you can't simply stab through with the needle. You have to make an initial incision, and it means you have to use viscoelastic. Whereas with the original design, we didn't have that, and we could simply pierce through the eye without using any viscoelastic, and it probably means that the aqueous humor was more primary aqueous. But here you can see the needle now going through the trabecular meshwork, and we've engaged, you can see the tip of the needle just under the conjunctiva, and I'm going to start releasing the stent in the position that I'm happy with. So this is back in about 2007, this particular case. Sorry, 2010. So I'm concerned that the needle is going to penetrate the conjunctiva, so I'm just making sure the conjunctiva is mobile. Having the eye fixed to this device means that it gives you a spare hand to check the conjunctiva, to move the eyelid if you need to, and also to hold the introducing system with two hands if you need to. Sometimes you do. Now you can see the Zens stent just starting to come out, and the needle is going to retract.
Come back actually.
So you can see the retraction of the needle, and essentially that's the operation. So the needle comes out of the eye, and then we remove the viscoelastic, and that's pretty much the surgery.
Now I can hear him.
Sorry, you can hear me?
Yeah, I can.
So
I can. Yeah, I'm able to hear you now. In between, I was not able to hear you, but that's fine. Please go ahead.
Oh, sorry, I don't know what I was doing. Sorry about that.
Yeah, that's fine.
I'll shift my. So I'm not very good with webinars. You can tell I haven't had much experience. Sorry about this. So this is just some post-operative slit lamp photographs of one particular patient, and probably the first thing you'll notice is this is the stent here, and you'll notice it's inferior nasal, and this person had had two previous trabeculectomies which had both failed with pseudoexfoliation, and in 2010 had a gelatin stent, 220 microns outer diameter, and here you can see the gonio photograph going through the trabecular meshwork, and there's quite a nice bleb infranasally. But 9 years later, it's just starting to fail, and the pressure was starting to rise. This was last year. But that's not too bad for a drainage operation to go for 9 years. So this is another patient. It's also an inferior bleb. Now, just don't get the impression that I only do inferior blebs. Most of the time, probably 95% are supranasal, but this particular patient was his only eye. He was blind in the other eye from retinal detachment, and it also had a retinal detachment in this eye with a very high scleral buckle. So there wasn't room for a trabeculectomy or a Xen stent superiorly. It was pretty much occupied by scleral buckle. So I put the Xen stent infranasally, and so far, this is about 18 months now, he's been functioning well with a well-controlled pressure. This is a patient where the Xen stent rapidly failed, and what I hadn't taken into account was the fact that this part of the conjunctiva supranasally was quite heavily scarred. The patient had had a previous trabeculectomy, and the scar tissue had extended more nasally than I'd imagined, basically. So it was actually difficult surgery. So that was it. I just put this slide in to illustrate the great importance to me of having a healthy and fairly mobile conjunctiva, so that the aqueous humor can drain through the Xen stent into the subconjunctival space. So interestingly, one of our great hopes with this surgery was we thought, well, if we have very little trauma to the conjunctiva, we have a stent that has a constant diameter and the system is well controlled, hopefully we'll get very predictable blebs. Well, that hasn't worked out. The bleb morphology varies a lot, and we still get encysted blebs. We get blebs with the so-called ring of steel around the back of them sometimes. One advantage, though, of these stent blebs is they tend to be more posterior. Very uncommon to get them anterior, where they're encroaching across the cornea or very thin at the limbus, which perhaps you still see, and I certainly have seen quite a few of those sort of blebs with trabeculectomies, for example. You do need mobile, healthy conjunctiva. You can place the blebs or the stents inferiorly. And just a surgical tip is that this Xen stent here, you can see is pretty much bisected the junction between the trabecular meshwork and the scleral spur. So that's a gonio photograph there. There's the trabecular meshwork. And they tend to be always a little more posterior than you think. So I generally always aim for the anterior trabecular meshwork or Schwalbe's line, but usually it ends up going sort of posterior trabecular meshwork. Just some examples of results. These are our long-term results with the original tube, which measured 220 microns external diameter, and we only had 23 patients because it was a clinical trial. You'll see that the typical mean pre-op pressure was about 25, and then it stayed fairly stable. But mind you, there were some dropouts, so there were some failures along the way. And I think I've got the figures here. So we have a Kaplan-Meier success curve. So about 83% survived out to about 7 years, which is not too bad. And in this study, this phase 1 study, all of those patients had previous trabeculectomies and all had had previous cataract surgeries, bar one. So they were reasonably high risk for failure. And this is our qualified success group. So these patients were potentially on pressure lowering medications or not. The complete success group was much less successful. That is, these are patients who were not on any pressure lowering medications and had pressures less than 21. So there's about a 50% survival at 7 years, or 50% chance that you would not need any glaucoma drops at 7 years. But it compares pretty well with trabeculectomy in the same sort of cohort in trabeculectomies who've had either previous trabeculectomy or previous cataract surgery. This is simply just comparing it to another study from the United States. And these graphs here just illustrate the fact that the typical patient pre-surgery was on either 3 or 4 medications, and generally most of them went down to about 0 medications with some gradual increase over the next 7 years, which we expected. Now, one thing that is worth noting is that many patients need to have 5-fluorouracil injection. So with this initial surgery, we did not use any antimitotic agent, so no mitomycin C was used in any of these patients, but a lot of them received 5-fluorouracil injections. I would say about 60 to 70% did. And also bear in mind that most of these patients were elderly Caucasian patients, so they were definitely lower risk than South Asian or Indian patients. I think I had one patient who was of Indian origin on this particular study. This is simply someone else's, this is Schlenker's publication from 2 years ago showing results at 2.5 years, which matched those from a similar cohort of trabeculectomy. So the red is the Xen, and this is the Xen 90, by the way, the 90 micron, versus the blue, which is trabeculectomy. So fairly similar results to trabeculectomy out at 2.5 years. And perhaps some of you are wondering how well the inferior Zens go compared to superior Zens. Well, roughly the same. So the red boxes are the inferior and the blue are the superior. It's just worth noting the numbers are vastly different. So this is a study that I haven't yet published. We're just writing it up now. This 214 superior Zens, which are the Zen 45s, and 14 inferiors, which are a mixture of the Zen 120s and the Zen 45s. And you'll see that the pressure results are roughly the same. We couldn't find any significant statistical difference in pressure reduction at any of the time points. And this is for the Zen 45s, and this is comparing the Zen 120s. And you'll see the Zen 120s are roughly equivalent out to even 9 years, whether they're inferior or superior. My main worry about an inferior bleb is the risk of complications, but touch wood, we haven't seen any significant difference in the complications. You do get hyphemas with the Zen stent, about 15, perhaps 20% will get a hyphema. You do see hypotony in some of them, about 7%, but I've only had to use viscoelastic to refill an anterior chamber once in 250 cases, so it's quite rare compared to a trabeculectomy. We do see choroidal effusions, and again, I've only had to refill. That was the same patient who had quite large choroidal effusions. We filled her anterior chamber with viscoelastic. But again, most times, well, every other occasion, the choroidal effusions have resolved within a few weeks by simple observation. The one feature where I suspect there is a difference, but our numbers are not large enough to show it formally, is Dellen, and you do see more Dellen, the inferior Zen stent, so inferior blebs, and I guess that stands to reason the cornea is a little more exposed inferiorly. So it's just worth, if you are doing this, just worth watching that inferior cornea. So just in sort of practical ideas, some ideas to what we think are important for improving our own success rate. If we could make the eye fixation simpler, say without the 3 sutures, because that certainly makes the surgery a little more messy and takes a little bit longer, but it does make it a lot more predictable fixing the eye. Also, if we could avoid viscoelastic in the anterior chamber, I think that would perhaps help maintain that primary aqueous, and it may end up with a better result, less fibrosis, perhaps less 5 fluorouracil injections. I'm still not 100% happy with the gonioscopy. We're working on improving the gonio lenses. The disposable mirror magnifying gonio lenses are quite nice to use, so we do use them quite a lot. Also, there's some issues with the ergonomics of the current device. This is the current implanter, which is you get with every Zen 45. We don't have an axial position indicator, and I'll show you an example of why that's potentially useful in a minute. So this is an example of some conceptual ideas. The gelatin stent is a nice model for studying blebs because you're not actually cutting any of the conjunctiva. Now, this is a patient who's had a trabeculectomy, but imagine it was a Zen stent. This is the principal area where the aqueous is draining to, where the trypan blue, which we've just injected, comes out. But you'll see how the lymphatics have lit up here. And this is to just demonstrate how, even with trabeculectomies, the lymphatic drainage is important for producing a well-functioning bleb. Now, the one nice thing about the gelatin stent is that you're minimizing conjunctival trauma, so it's one variable that you can discount out of the mix. So if you like, when you're studying function of the of drainage bleeds. So we've been looking at ways to measure lymphatics. We're looking at a OCT technique to image lymphatics. Professor Yu is driving that project. We're hoping we'll get some good results in the near future. We had our first patient lymphatic identified just 2 weeks ago, where we could actually see the lymphatics. Patient who'd had a Zens stent and 6 weeks post-Zen, the system was able to identify lymphatics. So this is without any tracer dye. So we're excited about that particular work. Now, I just thought I'd compare two techniques. This on the left-hand side is the technique which is being promoted by the company. So this is where you have a paracentesis, you use a hook. This is the system that we've used with a 3-point fixation. If you look here, you'll see there's a bit of distortion going on, and it's harder to control the position of the eye, and also you've only got one hand free, whereas with the a proper fixation system, you can actually control the eye position. I think you get less distortion, and you've got a bit more control over the delivery of the Zen stent. But that's of course I'm a bit biased. It happens to be the technique that I use, but I really just wanted to put that up there so that if any of you are thinking of doing Zens, you don't necessarily have to follow the technique that promoted by Allergan, although I shouldn't say that really. So this is just another example of our current technique. We were mixing mitomycin C with the local anaesthetic, but I've gone away from that. Had a few blebs that looked unnecessarily ischemic. So at the moment, I'm giving subconjunctival lignocaine and then giving a small dose of mitomycin C, which is measured. And in Caucasian patients, that's only 5 micrograms. So I give typically 5 micrograms, very posterior, in the deep tenons, and that's the mitomycin. That's 5 micrograms of mitomycin, a very small dose, and then you're ready to do the Zen stent. In East Asian or South Asian patients, I'll use perhaps 7 or 8 micrograms, but I won't use any more than that of mitomycin C, and again, very localized. So this is the same technique, and what I'm doing is just massaging some of that local anaesthetic so that there's room for the Zen stent to go into and minimize the risk of puncture through the conjunctiva. So that's entering now with the implanter and the stent. And this is the indirect magnifying mirror gonio lens. This is available commercially from Katina. It's very hard to get a good video of the angle, but I think you'll appreciate that I'm going through the trabecular meshwork, and then there's the needle, subconjunctival space, and we generally rotate the bevel of the needle a little bit, and then gently release the stent into the subconjunctival space. Often you'll see a hemorrhage, and you may get a little hyphema. What you don't want to see is a flick. You will notice on some videos that you'll see a sudden movement of the introducer, and if it flicks backwards, you can actually cause a cyclodialysis, which you don't want to do. So that's another advantage of having the eye fixed and having 2 hands on the system. So these are some post-operative images. This is from a website, OCT scan showing the Zen stent sort of wiggling its way through the sclera. This is what we tend to get from our patients are quite a straight line through the sclera. It generally indicates that there hasn't been much distortion of the eye during insertion. The typical appearance, the anterior chamber, here under the conjunctiva, you can see a nice bleb, and then this is the position and the angle. Now, I think I've shown you these slides already. This is the that same patient with a very high scleral buckle, high myope, blind in the other eye, previous retinal detachment. And so it would have been very difficult to do a trabeculectomy or even a glaucoma drainage device. So fortunately, a stent is working well infranasally. Now I will show you the full range of indications is not yet clearly defined. So a group in the United Kingdom have been saying that the Xen works quite well in uveitis. I think it probably does in low-grade uveitis. I'm not so convinced about the more active chronic uveitis. We've recently published a series of 4 or 5 patients who've had irido-corneal endothelial syndrome, who in the short term, so 6 months to 9 months, have done quite well with the Xen stent. This is one of those, a 24-year-old with eye syndrome, pre-op pressure of 40. You can see the pupil distortion, the iris hole here, and also you can see the Xen stent through the trabecular meshwork. There are some peripheral anterior synechiae present, and touch wood, he's done quite well so far. So it could well be that the Xen stent is useful in irido-corneal endothelial syndrome. This is a patient who had basically a choroidal hemorrhage which blinded her other eye post-Maltino tube. She's a very high myope, minus 20 diopters, and she was terrified of having any glaucoma surgery on her only eye, given the story in the other eye. And it wasn't until her pressure went up to 42 and she was rapidly losing visual field that she agreed to have surgery. And the Xen stent probably was the safest option, and it was used, and fortunately it's done very well. So she's had a very well-controlled pressure first year post-surgery. A couple of other things, you can repeat them. So here's an example of a patient who had a blockage in very ischemic looking bleb here, unfortunately. This case was done elsewhere and the patient presented with endophthalmitis, fortunately did well with intravitreal antibiotics, but nevertheless was left with this very ischemic looking bleb. And so I'm personally very careful and worry about the use of mitomycin C. This patient yes, this patient had a Xen stent in January 2018, and it failed very quickly. It scarred in spite of multiple 5-fluorouracil needlings. If you look very carefully, you'll see these funny little deposits in the lumen of the Xen stent, and I don't know what they are. He did not have pseudoexfoliation or any other, or uveitis, so no apparent cause for creating such deposits. Now, that patient went on to have a trabeculectomy later that year, which also failed within a few months, in spite of 5-fluorouracil needlings, and then basically went on to have a Maltino tube, which fortunately has done quite well. So for some reason, the Xen stents, they can fail, and unfortunately often a trabeculectomy in the same patient will fail as well, presumably for the same reasons. Now this is a patient, notice how the stent is sitting quite nice, it's just in a little bit in the anterior chamber. Now you'll see it's moved axially along the track into, as I've been checking for the position of the distal part of the stent, but as I was doing that, it's moved axially. So that's one trick or one trouble with the Xen is that it can move backwards in the anterior chamber sometimes. And what you've seen me do there is attempt to reposition it deeper. Here I've realized it's not going to work. I've gone in, I'm grabbing the stent with a pair of retinal forceps. I'm going to reload the injector and then reinsert it, because I'm not happy with it being so long and not having enough in the subconjunctival space. So that's the Xen stent. I'm going to reload it now in the inserter and then basically reposition it in the eye. So there definitely can be some improvements made to the stent. I'll finish on one success note. This patient, 69-year-old, had a Xen stent in 2010. In 2019, it's still working well. And you can see the bleb with some microcysts here. It's the wider stent, it's 220 microns. So I'm going to stop here. And I think I've done too much talking. Thank you very much for listening.
Thank you. Thank you, Bill. That was
now I know there may be questions.
That was a great talk. I think
my pleasure.
Taking us through all the steps how you did it, and also it's becoming more and more popular, and a lot of people are being helped. So I think that's a very positive thing. So I believe, are there any questions, Vinay?
Yeah, maybe. Sorry, it says there are a few questions that I had for Professor actually. One was, you pointed out the importance of lymphatics, and you showed us a fantastic example that if the lymphatics were seen, then the bleb was successful for a much longer period of time actually. So is that an indication that you may wish to know if lymphatics are working, and if the lymphatics are working pre-operatively, then perhaps there would be a higher chance of success. You would be more confident that things are going to work out actually.
Yeah, look, that's a great question. I think there's really two questions there. So first question is, does the drainage operation work better if it's done in an area where there are more lymphatics? And we simply don't know. I mean, it's a great hypothesis. It sounds very plausible. At the moment, though, we don't have a way of measuring lymphatics without using an injection of a dye, and most patients won't want that, which is reasonable. So we don't have a way of answering that question. The other question is, I think definitely, we published a paper last year where we showed that patients with trabeculectomies did better if they had more connections with lymphatics. So if the lymphatics were connected over a larger area to the bleb, then the pressures were lower in those patients. So definitely lymphatic connections are related to bleb success, but at the moment we don't have any way of altering that connection. For example, we don't know if any of our drugs improve or detract from lymphatic connections. That's one reason why we're working to try and create an imaging system to image the lymphatics without the need for a tracer dye. We'd love to know, there are some growth factors for lymphatics related to the VEGFs actually, and so potentially it could be possible to apply those in patients post-operatively and perhaps encourage lymphatic ingrowth. But again, that's a hypothesis, there's no proof there. Sorry, it's a very long-winded answer to your question, Dr.
But thank you. I think that it does help me understand, and I hope everyone is listening in onto this actually. And then I had another question. There was a slide in which you showed graphs for a Xen implant that was that had an internal diameter of 45 microns versus 120 microns. Did I read it correctly? And
yes,
the results appeared to be same, or was the 45 micron internal diameter less effective?
Yeah, good question. So the Xen 120, we have results out to 9 years now, and that works quite well. The Xen 45 results, we only have out to 2.5 years. And our impression is that they probably are not as good as the Xen 120s. So we don't have formal proof yet of that, but the impression we have is that the Xen 120 pressures tend to be a bit lower than the Xen 45s. The other reason for saying that is that in that study with the Xen 120s, all of those patients had had a previous trabeculectomy, and all bar one had had previous cataract surgery, whereas with the Xen 45s, they're a mixture of patients who have never had surgery before, many of those. Also, some of them have had cataract surgery, but not many of them have had previous trabeculectomy. So they're a sort of easier, less risk to fail cohort, the Xen 45s, and yet their pressures I don't think were quite as low. I can show you those slides if you want to see them. Let me see. I can bring. That's the Xen 120s. And you'll see that the average pressure was about 14, 15. And then the Xen 45s here, this actually does quite a good comparison. This is the Xen. Now, unfortunately, we haven't got them to exactly the same scale, but the Xen 45s are here. Actually, they're pretty much the same as the Xen 120s, actually. So perhaps they are about the same. But our impression is that the Xen 45s need more needling than the Xen 120s did. And actually, they're harder to needle as well. But look, probably my most honest answer is we haven't formally compared them to try and equilibrate all of the confounding factors like previous surgery, etc.
Thank you. Dr. Surinder, can you take up the questions actually in the column? There's one from Dr. Alka Pandey. She would like to ask, and would you continue?
Let me see, where is the question?
You know, on the control panel, press on the questions, you'll see that doctors have been asking questions actually. Did you get it?
All of you are necessarily able to see.
Okay, let me start while you get it. Yeah, so there's a question from Dr. Alka Pandey, and she's asking if there is any risk of mitomycin entering the anterior chamber after Xen implant, and how long do we wait after injecting the mitomycin before we implant the Xen?
Okay, yeah. So you saw those videos, hopefully they came through. So I inject the mitomycin separately and quite posteriorly. There's probably 5 minutes or at most 10 minutes between injecting the mitomycin and implanting the Xen. And the mitomycin does bind to tissue, so it's not as mobile as you would think. Also, we've filled the anterior chamber with viscoelastic and implanted the Xen. So if there is any free fluid close to the delivery point of the Xen stent, I don't think much of it's going to come back. In practice, we haven't seen any adverse effects within the anterior chamber, like corneal decompensation or other adverse events. However, we have not measured corneal thickness or endothelial cell count before and after Xen stent surgery. So that would probably give you most comfort if someone had done that, but I confess we have not done that.
Dr. Pandav, can you take the next question?
Yeah, Bill, just again as a hypothetical question, but do you think using mitomycin C may not be, good for the lymphatics?
Yes, I've wondered that. I think you're right, actually, Surinder, that those ischemic white blebs that you sometimes see probably have got no lymphatic connections, and they're probably bad news. So that's one. I'm sort of frightened not to use mitomycin C. I'm sure you're all in the same boat. You remember the patients who failed trabeculectomies when you didn't use mitomycin. So, but I've minimized my dose to a very low level, basically. And it may be that the dose I'm using is virtually homeopathic anyway.
Bill, are you doing any trabs now? It's all.
I haven't done a trab. I think the last trab was 12 months ago, about a year ago, actually. Now, I sound like a bit of a salesman, and I don't want to sound like that. We have there is discussion still about whether the gelatin is permanent or whether it will dissolve gradually. And we simply don't know the answer to that. So I think one question that everyone should bear in mind is how permanent is a Xen stent going to be, and how permanent can it ever be? So for example, we've got the Xen 120s going out to about 9 years. My impression is that they may start to fail, but 9 years is not bad. So if my trabeculectomies on average last 9 years, I'm pretty happy with that. But we don't have long-term follow-up on the Xen 45s. Yeah.
As you mentioned, originally you designed Xen so that it gets dissolved and leaves a track behind, which is endothelial growth along it. So.
Yeah, exactly. That was the idea back in 1996, and I think you were in the laboratory.
Yeah, I did see some of those rabbits actually, so that was quite fascinating.
Discussions probably when you were in the lab, actually.
So there's a question by Dr. Santosh Bhide. He asks whether we can use it in neovascular glaucoma.
I can see a question about, can it be used in neovascular glaucoma?
Yes.
Do you want me to
yes.
answer? So, well, you can be used anywhere, but I don't think it'll succeed. I've actually tried it in, I had 2 patients who I put in Multino tubes, and for some reason the Multino tubes were not working very well. So I thought, as a desperate measure, I'd try a Xen stent, but it failed within about 2 weeks. So I think the short answer is no. I wouldn't even bother trying to use a Xen stent in a neovascular glaucoma. I've seen other surgeons try it as well, and it's failed in every case that I've seen. So short answer is no, I wouldn't try doing it.
There's another question by Dr. Mandar Paranchpe. Is there a risk of implant dislocation internally and externally?
Okay. I think what you mean is there a risk that the implant will move and, if, in a sense, sublux, either into the anterior chamber or go back the other way into the subconjunctival space? And I showed you that video where you could see a little bit of, if you imagine, sorry, I'm not very good on the video. If you imagine this is the stent where it sort of moved axially, and I'll just describe this. So the 27 gauge needle creates a a track through the sclera that's about 400 microns in diameter. But the Zens stent, as it is now, is only 90 microns. Now, when it gets wet, it swells a little bit. So it might swell to be 150 microns. However, that still means there's a fair gap in that track. And so a little bit of force can push it back towards the anterior chamber, or even push it towards the conjunctiva in the first day or two. So in the first day or two, sometimes I see the stent more in the anterior chamber than I remember leaving it when I did the surgery, particularly in some patients with very tight eyelids, where it's almost like the eyelid sort of pushed it a little bit. But after the first day or two, what happens is that the sclera is starting to heal around the stent, and the stent is swollen, and it almost locks it into position. And I've never seen it move after the first few days. Now, I think I'm just going to extend your question a little bit. Can the Zens stent sort of poke through the conjunctiva? That's something that I've worried about, and yes, it can, unfortunately. So sometimes, and I don't know why, but I think if you're unlucky and just the way it goes through the conjunctiva, you have a bit of fibrous tissue underneath, which, because it's flexible, it causes it to poke up like a little snorkel and push on the conjunctiva. It can, and I have seen it work its way through, and then you have a full thickness leak of aqueous going into the tear film, basically. And that's a nasty situation. You want to avoid that, because you can get an endophthalmitis, and that has occurred to other surgeons. And it's also not easy to treat. So many of us have just tried putting one or two sutures to pull the conjunctiva together, but usually the leak will remain. And often you have to do a formal surgical revision where you excise some of that conjunctiva, pull down a conjunctival flap towards the limbus, and suture it very tightly. So there are, like a trabeculectomy, when you're managing blebs, there are various problems that you can expect to encounter, but there are different sort of problems sometimes that you will encounter with the Zen bleb. So look, I realise I've gone too long on your answer. I hope I did answer your question, though. Yeah.
Thank you, Professor. And there's one more question by Dr. Ranjit Mukherjee. He would like to ask if it would be useful to use the Zen in a post-vitrectomized eye with silicone oil.
Yes, no, it will fail, actually, because the silicone oil, usually there's always some left in the anterior chamber, and that will, because the Zen stent is 45 microns, it'll block that Zen stent very easily. So I haven't done it myself, but I would almost certainly guarantee you that it will fail, unfortunately. I think you really need to use a glaucoma drainage device in that situation.
I had a question. You know, when the Zen doesn't work, when the bleb fails, that's because there is a fibrous tissue that's formed to block the opening in the subconjunctival space. Is that what you found?
Yes, I think, well, there's probably 3 or 4 causes. So the first cause can be a blockage internally. So if you're unlucky, iris can come up and block the stent, or you can get little deposits. I've had 3 cases of deposits blocking the stent, and I don't know the cause of those yet. So that's internal blockage. Then external is, as you say, fibrous tissue, scar tissue forming around the end of the stent, creating a plug. If the stent is here, creating a plug there. And you can generally get rid of that by needling with 5-fluorouracil, pushing, but it's not that easy because the stent is so small, you have to try and get the needle just under the stent and push the fibrous tissue away, and then also go over the top of the stent and push it away as well and cut back and forth. But most times it works. And then, sorry, there's another Oh, sorry. Then the other reason why I've had some patients where, and you've probably seen this with trabeculectomies as well, where you have a beautiful bleb, like it's a big, nice, wonderful looking bleb, but the pressures are still high. And I think that's due to lymphatic failure of some sort. So the bleb is forming, but the lymphatics are not connecting. But we haven't got, at the moment, we don't have a way of proving that.
Thank you. Thank you. That's been great. Surinder, would you like to ask any more questions?
Do you have any question for the audience? So that's, I think I can't see actually those questions. Okay,
actually,
could you do this procedure equally well in like pseudo-phakic eyes and the phakic eyes, or like most of the MIGs there with the cataract surgery? So does this procedure need? Yeah.
It's actually easier to do in a pseudophakic eye because you've got a deeper anterior chamber, and also when you first start doing them, you're worried that your needle across the anterior chamber is going to hit the lens. You don't have to worry about that when they're pseudophakic. And that was the reason why our first study, we chose patients who'd had cataract surgery as well as trabeculectomies, so that we didn't, and we weren't using viscoelastic then. So I was worried that just a little bit of aqueous leak would flatten the anterior chamber and I'd be hitting the lens. So it's ideal for patients who are pseudophakic, but we do a lot who are phakic as well.
And when you place it under the conjunctiva, what I gather is you have to place it under the conjunctiva. You have to get past the Tennant's capsule with the needle.
Yes. Ideally, you want to go into the sort of upper tenons, superficial tenons, really, if you can. I don't think you have as much control over that as you'd like to have, really. I don't. But if it's only just gone through episclera, then they will tend to fail more easily. It seems to cause more fibrosis, and it's very hard to control that. Whereas into mid or superficial tenon seems to be ideal. We're looking at that at the moment. We've got one of our registrars is using anterior segment OCT on about 100 of our Xen patients, identifying at what layer of the subconjunctival space the end of the Xen resides, and we're going to look and see how that correlates with outcomes. So we might be able to have a more definitive answer for you.
Thank you so much. Surinder, do you have any other questions?
No, I think we had enough.
Okay, wonderful. I'll leave, but thank you very much, Professor. And I'll leave Surinder to make the last comments and give his thanks.
Thank you very much, Bill. It was wonderful having you with us, and we have exceeded the time a little bit, but not too much. I hope it's okay. And we look forward to more interactions in future. And whenever you come towards India, I think just let us know, and we'd definitely like to have some in-person meeting as well with you sometime in future. And thank you very much for giving us this time and taking us through all the intricacies of Xen implant. And I'm sure all the audience will be benefited by this. Thank you very much, and thanks, Vinay, for organizing.
No, my pleasure. Thank you, Professor. Thank you, Surinder. Thank you. A word of thanks to Dr. Sarang and Dr. Prabhat, my team. They are the one who did all the background work. And thank you, everyone, the audience, for being with us. And I hope everyone has had a good time today. Thank you.
Thank you. Thank you, everyone. Thank you very much. Thank you, Surinder.